Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
My name is Stephen Liu, Associate Professor of Medicine and Director of Thoracic Oncology at Georgetown University in Washington, D.C. For patients with metastatic non-small cell lung cancer that does not harbor a driver oncogene, our current standard of care is immunotherapy. Multiple trials have shown that immunotherapy-based treatment offers a significant survival advantage over chemotherapy alone. Using chemotherapy alone in the absence of a contraindication is simply no longer good enough and below our standard of care. The challenge is that there are several different strategies we can use to deliver immunotherapy. So how do we choose which regimen is appropriate? Our decision is first informed by expression of the protein PD-L1 on tumor cells. This is performed by a test called immunohistochemistry, done on a tissue specimen, not blood. If PD-L1 is positive or detected, we have one set of options. If PD-L1 is negative or not known, we have a different set of options, though there is some overlap. For PD-L1 negative tumors, the approved options are immunotherapy combinations. Most commonly used are combining a PD-1 or PD-L1 antibody given intravenously with standard chemotherapy. The specific regimen is informed by the histology, the subtype of non-small cell lung cancer. The most common is non-squamous non-small cell lung cancer, primarily adenocarcinoma or large cell carcinoma. For this subset, the combination of carboplatin, pemetrexed, and pembrolizumab, a PD-1 inhibitor, is a commonly used and effective regimen that offers a survival benefit over standard chemotherapy. This was based on the large phase 3 randomized KEYNOTE-189 trial, where the addition of pembrolizumab to chemotherapy improved survival, doubling the median overall survival and improving the one-year survival rate from 49% to 69%. This benefit was seen across PD-L1 subtypes, including PD-L1 negative, where the hazard ratio is 0.59. Another FDA-approved regimen comes from the Empower 130 trial. This explored the combination of carboplatin and nab-paclitaxel given with the PD-L1 inhibitor atezolizumab. Here, the addition of atezolizumab to chemotherapy improved survival, hazard ratio 0.79. It is difficult to compare across trials, but the important difference between these two studies are the chemotherapy backbones, as these have different toxicity profiles, different pros and cons, and so it is good to have multiple options. The Empower 150 trial looked at a 4-drug regimen: carboplatin, paclitaxel, the anti-VEGF antibody bevacizumab, and the anti-PD-L1 antibody atezolizumab. This also improved survival. Here, the hazard ratio is 0.78, an encouraging regimen in different subsets of lung cancer, including patients whose cancers have spread to the liver, a subset of patients where outcomes have historically not been as good. For squamous histology, there are different regimens used. Here, the phase 3 KEYNOTE-407 trial looked at a combination of chemotherapy with carboplatin and either paclitaxel or nab-paclitaxel, given with either pembrolizumab or placebo. Here we saw that the addition of immunotherapy, pembrolizumab, to chemotherapy in squamous lung cancer also improved survival. Hazard ratio here is 0.64. Another interesting combination is dual checkpoint blockade with ipilimumab, a CTLA-4 antibody, and nivolumab, a PD-1 inhibitor. In patients with tumors that are PD-L1 negative, this combination improved survival. The hazard ratio was 0.64 with a median survival of 17 months and a quite impressive duration of response of 18 months. Technically, this is only approved for PD-L1 positive tumors, and so use in PD-L1 negative non-small cell lung cancer is off-label use, but I do think it is reasonable and supported by the data. The most recently approved regimen is based on the phase 3 CheckMate 9LA trial. This trial explored the combination of nivolumab, ipilimumab, and chemotherapy, but the chemotherapy was only given for 2 cycles and stopped early. The phase 3 trial was for patients whose tumors did not express mutations or rearrangements in EGFR and ALK, but was across PD-L1 subsets and for all histology. This was a positive trial. The combination of nivolumab, ipilimumab, and 2 cycles of chemotherapy compared to standard chemotherapy improved survival with a hazard ratio of 0.69 across major subtypes, including squamous histology, and across PD-L1 cutoffs, including negative. As expected, there was more toxicity. 47% of patients had a grade 3 adverse event, and about 1 in 5 patients had to stop due to toxicity. At the same time, because the chemotherapy was limited to 2 cycles, there was less myelosuppression, likely reflecting the lack of cumulative toxicity of the bone marrow. Overall, immunotherapy should be part of our standard approach for all patients with driver-negative non-small cell lung cancer, including PD-L1 negative tumors. Saving immunotherapy for later is not an appropriate response. But we do have multiple options, which could include dual checkpoint blockade or combination chemoimmunotherapy strategies. Selection of a specific regimen needs to be individualized based on specific clinical circumstances, comorbidities, and certainly patient input, though a clinical trial with novel combinations may also be an option for some patients.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate and visit us for more information at cancergrace.org. Thank you for listening.